Sup, guys? Welcome to the PT Good Podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
And my name's Mark.
So, Mark, what is on the agenda for today?
Kane, today we will be talking about the thoracic spine. So, previous couple episodes we talked lumbar, we talked cervical in regards to radiculopathy. Today we're going to talk thoracic, maybe not just in regards to radiculopathy, but just about thoracic pain, assessment, intervention, thoracic spine in general. So, Kane, why don't you start us off? We've talked about this a little bit in our lumbar and cervical episodes, but thoracic's right in the middle of cervical and lumbar. So, do you find that it has any influence on cervical and lumbar spine?
Yeah, it's so funny because in the MDT world, or at least what I think people kind of mistake the MDT world as, is just everything is cervical or lumbar. It's just press ups and it's just retractions, right? But just like Mark said, the thoracic spine is the junction for the cervical and lumbar spine. It is so common to see how thoracic can influence both of these structures. I think it is such an important thing to take a look at, not only if you are heavily influenced in the MDT world, but just if you're looking at it from a mobility standpoint. Like, I know plenty of people that will give their own version of a repeated thoracic extension just to help them with their thoracic mobility, or they'll give like rotational work to improve on that. But essentially, regardless of what school of thought that you come from, thoracic is such an important thing to consider. I know even like going through PT school, they'll say like one of the top manips that if you learn how to do, like, this is going to be your bread and butter, and it's going to be a thoracic manip. It's so safe to do. It is also going to help address a whole lot of things, from headaches to shoulder issues, and also actual thoracic or rib cage issues as well too. So I definitely think that thoracic is overlooked a lot of times compared to cervical and lumbar, but it's just one of those things that you gotta pay attention to it. You gotta know what you're looking for. And at least in the MDT world, it responds so similarly to repeated motions, the same way that cervical and lumbar do.
Yeah, definitely. I mean, even if we stray away from MDT, like if you're just thinking about it from a strictly mechanical standpoint, and I mean, this comes into, mechanical MDT. All right, biomechanical standpoint. In order for your cervical spine, especially lower cervical, to extend and move, and for you to be able to be upright so that you can rotate and side bend and have full cervical range of motion, a lot of times you're working from the bottom up, right? So you need that foundation of a little bit of relative thoracic extension to be able to have this full cervical movement. So sometimes you have someone that's just really limited cervically, and you just need to start bottom up. And where are you going to start? Thoracic spine. So it certainly has like a strong influence on cervical in some cases. What about the lumbar spine? I mean, we talk cervical, it kind of makes sense. How about, where does it fit in for lumbar?
Man, so I don't see it quite as often, and I think that's definitely something that's important to note. Like Mark said, I see thoracic influence cervical so much more often. You know, like when you are going through retractions, you want to get upper thoracic extension. Like, it needs to move. But for lumbar spine, this is usually where I see a couple of different things. You know, like, most of the times, unless someone is a hinger, they're usually just going to respond well to the normal repeat extension and lying. But when someone hinges, or they're lacking overall mobility in their lumbar spine, like Mark and I were discussing this when we were planning this episode, but when someone does a press up and their hips start to lift up off the table, that's usually some like that could be an indicator for me, like to look at their TL junction. Maybe we can get that lower thoracic upper lumbar moving a little bit better, and that's when we start to unlock things and get the rest of their spine moving better in general. Do you When do you typically notice that it is an issue for you, like at least the TL junction or the lower thoracic spine when you're taking a look at lumbar?
Yeah, I can't say I found any strong indicators, and just like you had mentioned, it's not compared to using the thoracic spine to influence the cervical spine. I'm certainly not going to the lower thoracic to influence the lumbar nearly as much. But if I mean, I base it off pain location. If we're looking at it's localized upper lumbar, yeah, we're going to address it. And they're not complaining of any lower lumbar issues, then maybe we're looking at like the lower thoracic influencing that lumbar area. Another thing I look for if they do have radicular symptoms is if they're having maybe some symptoms in the L1, L2 dermatome type area. So if it's like pretty proximal, anterior hip, like pelvis type area, I might, and I'm doing my regular lumbar stuff, and maybe I'm getting some kind of response. Maybe if it's a yellow and it's really not sticking, I may look to influence the pain in that area by targeting higher segments, right? So then maybe we're going to like a press up with the hands farther out front just to get a little bit more targeted in that lower thoracic upper lumbar area.
Yeah, I've even noticed that going into the anterior thigh is something that I'm typically taking a look at. I remember one patient in particular. He was a very interesting case, to say the least. Like, I ran through the full progression with him, and this is when I was quite green in my utilization of MDT. Like, I knew the force progression. I kind of understood how to interpret the information, but I was just lost on determining and being confident in my interpretation. And he was like such a weird presentation, could not extend whatsoever. Any extension peripheralized everything, right? But then we moved on to upper lumbar and or lower thoracic, and that started to improve and change some of his symptoms. But the weird thing is, he responded to whatever movement that I really gave him. He responded sometimes to flexion, sometimes to flexion rotation, sometimes for thoracic extension. I'm just losing my mind because I didn't understand or have the confidence to know that this guy was someone who was just mechanically inconclusive at that time. And honestly, he was someone who desperately needed an injection. Once he did, all of his symptoms were drastically improved and were finally mechanically responsive. So to kind of play off our last episode, when you have like suspicious symptoms like that, and you think that they may be mechanically responsive, but you're just like not hitting it, sometimes they really just need something to get them over the hump for them to finally be able to be reclassified and to be responsive again. You know, I think that's like, it's something that's important because it just helps us be able to flush it out a little bit more about how big of an influence thoracic potentially has on both the cervical and the lumbar spine, because he, even after the injection, he still responded, not to extension. Good God, that was straight up peripheralized all the way down, but he would still respond to addressing his TLJ. And that to me was just like, why is this a thing? How is this happening? It's not super common, but to me, it's something to keep in the back of your mind, or at least in your back pocket as a tool for you to take a look at when things just aren't making too much sense. So I think one of the things that I've actually played around with a little bit more when it comes to this, and this is one of the things that I mentioned previously, which is when someone does a press up and their hips come up off the table, right? So if I see this, I'm usually going to move to the standing variation a lot faster, because when someone has mobility like that, when they're offloaded, I think that they're just not able to tolerate getting themselves up all the way, or they're kind of like bracing because they just don't have that confidence to let their spine move. But if they're still not responding to the standing variation, that's when I'll actually get them back onto the table and I start to apply overpressure a little bit faster, because not because I'm looking for the force progression here, but actually because if they're not moving super well, I want to start to see if I can get them to move where I'm putting my hands. If they need movement,
something more targeted, right? Like you said, if their hips are coming
yeah.
off the table and like, right, technically, at least the way it's taught to me, like that repeat extension line, like their hips can come up, but there's a difference between someone's hips coming up and them feeling strain in the correct area versus the person whose hip comes up and they're just like you said, bracing and then just not letting their spine move. And in that case, like I see where you're going with this, right? You want to get some kind of movement within that segment so you can gauge if there's any kind of symptomatic response. So might as well get in there and hit that area.
Yeah, for sure. It doesn't need to be a terrible amount of pressure. Like if
Yeah,
you're familiar
right.
with the with clinician overpressure, for the most part, it's not a lot of pressure. You're just giving them enough and then letting them be able to move through that. And I think I kind of follow the same exact thing here is I just give them enough pressure that they're like, oh, this is where I need to be like extending from. And when we see that, that's where I'm like, okay, how are your symptoms changing now? And a lot of times, if you pick the right candidate, you're probably going to see that change, right? And I do think that that does come from clinician experience, pattern recognition, so on and so forth. But for the most part, I've had fairly good success when it comes to people who are just struggling, who are in like the appropriate age group, who seem like they should be responding to repeat extension line, but nothing is really sticking. Just going up a little bit more upstream, I've had quite a bit of success when I am hitting like a plateau and I'm like, this is just not really adding up. Where do we go from here? Right? It just gives you something to add into your toolbox to take a look at when you're like, I don't know where to go. Like it seems mechanical, but it's not. Yeah. And then lo and behold, you just need to look a couple segments higher, or maybe a couple segments lower if we're talking about cervical spine.
Yeah, and it's just like you're talking about applying clinician generated forces, like when you're gauging the response to, I mean, the way you pick a segment is just based on symptom location and just kind of basically your best guess, right? So if you're wanting to target a certain area and you want to gauge your response, it's that simple. Or you can just pick different segments, different areas, see what helps the person, and then you just start there. And like Kane's saying, if it's something you feel like it should be responding to a lumbar extension variation, something like that, but it's just not coming along, and move a couple segments up and see what happens.
All right, so we talked a little bit more, and I'm sure we're going to discuss this a little bit more in depth, but like we said before, thoracic is such an important thing to look at when it comes to both cervical and lumbar spine. But let's talk about where we can look at isolating the thoracic, right? What types of presentations we might see for these things. And I know the one thing that just sticks out in my head, and I think it's so funny because while we are discussing about this, in my head, this makes complete sense, which is when a patient complains about wraparound pain that is going around from their maybe their thoracic into their rib, and then maybe even into their chest or into their shoulder. But it always is that similar wraparound pain. It doesn't need to even go all the way anterior. It could just like stay lateral. Sometimes I've seen it where you just get straight anterior pain, like just chest pain, and it ends up being from their like essentially a thoracic radic. And I don't know about you, Mark, but when I see that, I'm like, we got to get them moving. Like I can almost guarantee you that it's going to be some sort of thoracic involvement where if you get them moving better, those issues are going to start to resolve.
Yeah, I mean, for sure. I mean, if you just take a look at, if we're just going to base it off something simple such as dermatomes, like, I mean, if you just look at the associated thoracic segment, it just wraps around like that, right? So it kind of follows the rib line. So if you have that wrapping around type pain, set to chest, even if you're like lower down, those lower segments, to me, it's like, okay, it's thoracic's on my radar right away. Compared to if it's like, and you're talking wrapping around like posterior anteriorly, correct? You said chest
Yes,
stuff like
yes,
that. So like
yes.
this is compared to if they just have pain posteriorly and it's, let's just say, like T7 or above. To me, I'm still, could it have still be thoracic? Yeah, but I mean, to me, it's cervical until it's not. So I'm still testing cervical. But if it's that wrapping type pain coming around to the front, yeah, it definitely puts thoracic higher up on my list. Anything else that
Yeah,
you see, like history wise, that would, apart from pain location, that you think, okay, we got to check out thoracic?
hmm. History wise, I
Oh, just sorry,
think.
like presentation. I mean, maybe not just like what they're, yeah, what they're telling you, presentation, things you look at.
Okay, okay. Thanks for giving me a couple of other options. I was like, wait a second, this is a little bit trickier. Usually, their history is like when they have that wraparound pain, when they don't have a necessary like mechanism per se. That's usually when I'm thinking that they're going to respond more to repeateds. When they have a mechanism, that's when they may or may not respond to repeateds from what I've noticed, and they may need a little bit more force to get them going from like the initial like evaluation or even the first follow-up, and then they may continue to respond to repeateds following. But I think one of the big things is like you're gonna notice movement restrictions. So, like this is the same thing for cervical and lumbar, just like we said before. If they're having symptoms like that, they're usually going to be limited in extension. They're going to be limited in rotation or in side bending. Like these are all the ways that you pretty much close down the thoracic spine, and I think that that's typically what I'm noticing. If it's like especially limitations that are unilateral, then I'm like, okay, we're probably gonna have to do something about this here. Maybe they respond going through sagittal movements and directions, but I've noticed that a lot of times, I don't know about you, Mark, but for thoracic, I end up having to go lateral a lot compared to um the other segments. Say for maybe cervical, but
Hmm.
it's definitely up there. Like I definitely have to do a fair bit of rotation, and I check that pretty quickly too.
Yeah, especially, I mean, like unilateral type pain, like it's already perhaps an indicator for having a relative lateral component. I mean, yeah, certainly it could also just be that the pattern of peripheralization in that region. So you're right, we're always starting sagittal, but yeah, just to answer your question, do I go lateral? I'm trying to think. I mean, I feel like the last like true thoracic I had was a ipsilateral rotation type one. So listen, just
Okay.
like
Yeah.
just like
Yeah. Yeah.
most things, I'll agree with you. But
Oh my
um,
god.
but
But
this is
there
also
is
this
something
is
we don't.
yeah. Oh God,
That's
no, we're
later
getting
on.
it later.
That's
Jeez,
later
don't get us
on.
started. But this was, I'll say this: I find that the mid to lower thoracics typically have a higher chance of responding to a lateral like rotation compared to the like mid to upper thoracics, which I find are more typically sagittal plane extension responders. What do you think of that?
I I would agree. I would, yeah, actually. Most issues, to be completely honest with you, for thoracic, they're usually going to be mid thoracic, right? Like I don't see too
Yeah, yeah.
many things that are, if it's upper thoracic, it's probably cervical,
Yeah,
right?
like
Like
yeah, I was just gonna say, like we talked in the cervical episode, like the pattern for peripheralization for a cervical radiculopathy would be right, like close out to your shoulder and then down the medial ward of your scapula almost down to inferior angle, which is that T7 type area, and then coming back up down the arm, right? So, like Kane just said, if it's upper thoracic, especially if it's like that scapular-ish type pain, yeah, I mean, in my mind, that's cervical.
Yeah, and I think that when it comes to addressing upper thoracic, right? Like there's a couple of things. I feel like retraction is already going to be hitting that. Retraction extension is already going to be hitting that versus like actual, like the traditionally shown thoracic extension, that's usually not getting upper thoracic. It's mostly mid, right?
Mm. Like traditionally, like over a chair type thing, right?
Yeah.
Like, it's just, like, it's not upper unless you're adding like a cervical retraction and extension with it, and they're really reaching, and they have enough like cervical extension to leverage the weight of their head over the back of the chair to hit upper thoracic. I don't think it's really getting that area. Yeah.
Yeah, I've messed around with this a bunch. And I've kind of flip flopped to see what I like, what I'm seeing, and stuff like that. I am not a fan of the over the chair version unless it is like truly mid thoracic. But even then, I just don't default to that because I found that if someone's stiff in their thoracic and they're a hinger, that's going straight to their lumbar. Like there's just no other way around it. Yeah. The one addition that I make is usually putting a foam roller, a half roll behind them. That will help sometimes. But for the most part now, I don't know if this is frowned upon in the MDT world, but I will usually have the patient do this with their hands behind their head. And then depending on the area, if it's upper thoracic, like CTJ area, I'll have them pinch their elbows together a little bit more. And then I'll have them tip forward in their chair and then just extend, reaching their elbows and pushing their chest up to the ceiling.
That's the described procedure in the MDT world, correct? Exactly what you described. Elbows touching, and it's like a reverse hinge, chest upwards. You don't use the chair. You scoot forward in the chair. Yeah. Good job. You did it.
I am MDT.
That's exactly. Yeah. So in that case, yeah, you can get upper cervical, in my opinion, because, I mean, you're taking the neck out of it, right? But that chest up and forward, yeah, you're going to get upper and mid.
So this is the thing, right? If you teach your patients how to find that position, you can teach them to fine tune it so much better. And this is the thing that I love so much. I get it. I've talked to a couple of my mentors about this, and I'm like, do you always do this? And they're like, yeah, it helps to standardize the procedure. And I'm like, okay, I get that. But what if it's like just not working for some of your patients, right? So this is where, to me, I would rather have that higher skill floor. That way patients are better able to tailor the intervention more specifically to where they need. And then I teach them, this is what it feels like. Here's how you replicate it, right? And when they're able to do that, they're able to figure out, okay, this is where I'm tighter, and this is what probably needs more TLC to finally unlock that segment and get things moving better into resolve. And obviously we teach them test, retest. So that way they do it and they're like, okay, this feels better. Or they test and they're, oh no, this feels way better compared to the last version. Boom. They're already doing a lot of the work for you. You just have to coach them correctly. So I love that version. I think it's so funny because I thought I was a genius because I was like, oh my God, why don't I just do this? This is perfect. So yeah. I think it's so funny that you told me that.
Yeah, well, I mean, like the MOB's the same way, right? So I mean, we'll talk about this a little bit later, but yeah, it's that. But yeah, you can do it as like for patient generated forces as well. But the patient overpressure is using something to bend back over. But yeah, anyway.
So the next thing that I think that we should start to discuss a little bit more is thoracic presentations, how they may actually present themselves. I know that we talked about the radicular presentation, right? Which is that wraparound pain, or sometimes it can wrap into their shoulder, like literally goes across their shoulder blade, across their ribs, right into their shoulder. And that's where I've noticed that some of these patients, like that's pretty clear cut. It's way lower than what you'd expect. So this to me is definitely telling me thoracic. So I think before we move on, I definitely want to discuss like some of the force progressions that we utilize here, right? Because for thoracic, I don't know about you, Mark. I never really have to flex someone. It is almost always going to be extension or rotation. Like I can't think of anyone that ever had a flex. Lumbar, it happens. Cervical for protrusion, I don't really see it too much. You may see it for like headaches, but it's not a really common one. But thoracic, I can tell you, I have never ever flexed anyone. I don't know if that's the case for you.
Yeah, I mean, so here's the thing.
Okay.
Like, just a thoracic derangement, I think, is rare, and then furthermore, having one that's gonna need flexion is like 7,000 times as rare, right? So it's just so I don't even know. I'm trying to think if like taking the classes of going through, the faculty have mentioned anything about seeing one. I think maybe one of the guys like talked about seeing like one before. I don't know, but I don't really. I haven't seen them. Honestly, I don't expect to ever see one. So yeah, I mean now there are flexion procedures described. It's just, I mean, maybe just for the sake of it being complete, but yeah, I can't say if I've had the pleasure.
Yeah, I would definitely say the same thing. Okay, so with like I said, with thoracic, we extend typically. We can rotate as well, and I think that this is where the progression of thoracic, the force progression is similar to so many other treatment methods, right? Like when we have someone extend, it's just generalized thoracic mobility, right? When we do any mob, it's the same exact thing. You just got your hands on them. You're just doing your basic manuals. When you're doing rotation, that's pretty much just a mobilization with movement. The only thing that I think MDT does differently, and this is what people make fun of it for, is when we go ballistic, right? Is when we have patients do their own overpressure, which is where they're essentially throwing elbows, right? Like you are quickly rotating to generate force and giving a target for the patient to hit with their elbow. Usually I just put my hand close to the midline of their back, and then I have them turn to try to strike my hand with their elbow. So that way I know that they're getting the appropriate force and distance as well too. So that way we can see, okay, we added more force. What does this look like? But I think that's the only other one that's a little bit odd and different compared to other, I guess, other methods of treatment. What do you think? Is there anything else that you would add? Really, like I don't see side bending for this presentation at all.
No, there aren't even sides. I mean, at least from NDT perspective, side gliding isn't even really described for like thoracic.
For thoracic, right?
Right. Yeah. So you have extension, you have flexion, rotation, and like we talked about before, I mean, this asymmetrical presentations, we're starting sagittally, but rotation's an option. And the thing is, like, it's consistent in that there's a force progression. You're always gauging symptomatic response, going off your traffic light system, and then you're working from there. So like Kane said, like the thing that's a little bit different for the thoracic spine rotation is that you have the option for ballistic forces, which, when we go to like extremities, hip, elbow, things like that. Like, ballistic forces are described, and sometimes that may be required for reduction or symptoms to be abolished. But yeah, other than that, everything's consistent, right? Like I said, you got your force progression, symptomatic response, mechanics, and they're just kind of working based off movement.
Yeah, and so I think that kind of leads us to the next topic, which is various thoracic presentations, not necessarily a derangement, right? I think that for thoracic, you can get localized pain. You can also get diffuse pain, and I treat them very, very similarly. And these guys are usually going to have reproduced pain with rotation, side bending, or extension, usually to that side. The other thing that is going to be a big indicator is if they have pain with coughing, taking a deep breath, sneezing, or when they're bracing to lift something. Now, the one thing that I'll say, I said that's for thoracic presentation, and I might have lied a little. It's not just thoracic, it's also for ribs as well too, which we'll get into at the end of this episode. But these are all the indicators that I'm typically looking for. If someone points to their pain and it's like it's pretty isolated to their T-spine, I mean, for something like this, I'm probably going to look there, right? This isn't something that I tend to look upstream or downstream on a whole ton, but usually these patients are going to tell you, like, I can't turn to put on my seatbelt. I can't turn to reach something in the back of my car, or like, I have a lot of pain sitting straight up, or any of the other signs that I mentioned, the coughing, deep breathing, bracing, etc., or sudden onset of pain following a cough or a sneeze, or if they're going to lift something up that they didn't anticipate was going to be heavy. So we talked about MDT as a treatment. We got a little bit ahead of ourselves, but the other methods or interventions that I really like for this area is just manual skills, really, like mobilizing and manipping. I know Mark is the resident MDT expert, but is this an area that you also will get your hands on your patients a little bit more?
Yeah, when the last class I took where they discussed thoracic, I think the faculty who's teaching said that he felt that about 75% of thoracic derangements required clinician generated forces just to achieve reduction. I think part of that is because a lot of them are going to respond to extension, but naturally we're in a thoracic kyphosis, so in order to get that full extension, it may be hard for the patient to do that on their own. So what do you do? Well,
did you say 75%?
That's the number he used. Yeah.
Wow.
Listen,
that's
I'm not mentioning any names. I'm not trying to, throw them out there, but yeah, 75, right? So, yeah. And I think part of the explanation was that, yeah, let's think mechanically, you're in kyphosis, right? If you have this is why I used the term relative extension earlier, is that you might, like, when you're extending from a flex position already. So maybe you're not even extending the neutral. If you really need to get to end range and what your body's capable of, if you already have an obstruction to that movement, you can't get up straight. Yeah, maybe you need a little bit of help. So, yeah, you might need to get your hands in there. You might need a little bit of mob, manipulation. But, yeah, so I do find in this case in thoracic, and I'm trying to think of any thoracic I've had early. Yeah, I mean, clinically and anecdotally, I've found that, that 75% number has been similar for me as well.
Yeah, and I am a lot faster to jump to the clinician generated forces as well. And then that is when I usually see that these patients start to respond to the traditional repeated motions, right? And I think that's totally fine. Like, this is where knowing the framework, understanding it, and then how to incorporate your own practice is going to be super, super helpful, because some of these patients, like, if I just get them to move and they're not having a response, and then I mob them or manip them, and then after that have them go and do their repeateds, and they're like, oh no, that feels better. Their quality is a lot better. Their quantity is as well too. Maybe that's just what they needed. You just had to get them over that hump, kind of jumpstart that process, right? Now, talking about manips, Mark, what do you have any specific things that you're usually doing for like your manuals, any manips or mobs? Do you prefer one versus the other? Like I know for extension, plenty of people will do the one where they're like standing in front of the patient, they have the patient put their hands on their forehead, they lace their arms through to help facilitate that extension moment when they're like leaning forwards. Is that one that you use? Do you
Wait,
use
as a
the
mobilization or manip? Sorry, grade 5 mobilization.
Yeah, as a mobilization.
This isn't sitting.
Yeah, it's in sitting. It's the one where you're facing the patient, and then their hands are on their forehead, and you literally put your arms through the crook of their elbow, and your hands are rested on top of their shoulder blades, and they just lean forward, and you're pretty much doing a mob with movement.
So, man, I think you made that up on the spot.
Oh
and
my God, that's insane.
I've never heard of that, and I haven't used it, but
that's crazy. Oh man.
Listen, man.
I've seen it done at your clinic. That's so crazy.
Well, after you have to tell me who's done this, but okay. Now, so I don't know what that is, so I don't use it, but I go MDT style mode, right? So you said like hands, I go hands behind the head to the side, and then it's essentially mobilization with movement where you're tipping them up to get the thoracic extension, and you're giving a little bit extra overpressure on the spine. Okay. I'll do prone mobilization sometimes from, and I don't typically, if I'm going like grade 5, I'm not typically doing a prone. I'm usually going supine, pistol grip, and then hitting it from there. I just find it to be a lot more effective. I can leverage my body weight over it a little bit better. I can lock out the desired segment, if you will, a bit better. And I just find that to be more effective. But yeah, from a mobilization standpoint, I mean, MDT style, right? Prone, same thing, pressure on, pressure off, sitting, pressure on, pressure off. Those are my go-tos. Yeah.
I definitely agree with the MDT style mob. I find it to be way more tolerable for patients, and also the sitting version is fantastic, right? So if people aren't familiar with that, that's where their hands are behind their head, elbows are reaching forward, just like what we talked about before, and then all you're doing is you're just cradling their elbows and lifting them up into extension. You can use your opposite arm to press on their thoracic to help facilitate that extension. I find that you get way better range with it. But also the prone version, where you're pressing all the way on to end range and then backing off, that is way more tolerable for patients compared to just like giving them a consistent grade 4. You just can't breathe, and if they're in a lot of pain, they'll probably guard. And that's one of the things, like, I used to love that mob until I started playing around with MDT style a little bit more. I'm like, wow, I actually really prefer this, which I never thought I'd say. But in regards for the manip, I gotta agree with Mark. I can do I mean, I know 4 thoracic manips. I don't know if there's more than that, but I'll say that the ones that I utilize the most are the seated distraction one, as well as the pistol grip. I think that the seated distraction is just fast. It's easy to do. Patients are very comfortable with it. It usually gets the job done super quickly, and with very little setup. I think that the pistol grip is fantastic, though. That is probably going to almost always be my go-to and recommendation for majority of clinicians. If you can only do one, learn that one, because not only does it help you be able to localize your forces better, but you'll be able to transition to a rib manip a lot easier if needed. Now, the one tip that I would say, and this is something that I do personally, and it's how I was trained as well too. I've talked to other fellows that do not do this, but I think that it definitely has some merit, which is when you're positioning for your pistol grip, I usually will rotate my hand in some way, shape, or form. I'm looking to lock out that segment and create a little bit more tension. So for me, I usually radially deviate and then I usually extend as I'm getting them down from like side lying onto supine. And that helps me lock it out so much better. And then I hardly have to do anything. The setup's already done. I give them a little bit of pressure and it's already going to go. So that is my one tip, is just fine tuning your technique a little bit better for these. Now, let's talk a little bit more about following up with these manips, mobs, etc. Mark, do you have any mobility exercises that you typically will go to when it comes to follow up after mobilization for the T-spine?
Yeah, if we're just looking general mobility, I mean, I will still, excuse me, even if it's not demonstrating derangement qualities, I mean, I may still use these MDT. Mackenzie doesn't own these exercises; they're just movements. It's the assessment and evaluation method. But I'll use the exercises. I'll use those movements, right? Like we talked about that seated extension. You can teach the patient to target different areas depending on where they're feeling stiffness. One that I like for upper thoracic, and this is typically how I go to follow up after manuals or regaining mobility, is starting to use that posterior musculature to, get that mobility to quote unquote stick, right? I mean, we're speaking theoretically here, right? But so something that I like to do is maybe like, just like a standing facing away from a wall, isometric retraction into the wall, a little bit of neck movement, and then 90-90 at your elbows and shoulders, and a horizontal abduction, squeezing back. If the person's able to, wrists stacked over their elbows, and then they try and get into the back of the hands to touch the wall, right? So they're getting, it's more like a CTJ type thing, but you're going to get to some mid and upper thoracic extension. And I like the wall because it gives them cues, right? It's something to reach for. They have the external cues of their wrist and elbow stacked over their wrist and elbow stacked, so they know if they begin to reach and externally rotate with their wrist, then they're kind of cheating, right? So they're going to isolate that upper thoracic type area if they keep them stacked, and they're going to use their muscles to maintain the mobility. Yeah, so that's one I like.
So that's pretty much just a modified butterfly, but you're getting
not
more muscular contraction.
Yeah.
Okay. I like it. That's definitely, I'm gonna steal that one.
That might be I picked that up from an MTI fellow, so I don't know if it's a Sarman thing or what, but I like it. Yeah.
Yeah, it's good. Like, I think to follow up on that, one of the ones that I usually like are saying a similar position. A lot of these people are going to be seated, usually in front of a plinth or like a counter, hands behind your head, elbows onto the counter, and you are just pushing your head through your elbows. That is essentially going to help stretch your lats, but primarily what I'm looking for is getting them to drop their chest down to the floor while they do that. That is definitely going to help isolate upper and mid T-spine pretty well. The other one that I'm seeing is if someone has limitations in rotation, is I'll have them do a standing open book with their feet staggered. So when they do that, I really want to make sure that their hips stay squared, and that way you can isolate the rotational forces a little bit better where you want them to be, and just coaching your patient through it and teaching them and observing where are they getting rotation from, and then making sure that's at the spot that they want to feel it on. So I think that some of these are just like are go-tos for thoracic mobility. Are there others? Absolutely. There are so many thoracic mobility exercises, but I think these are just some of our go-tos. Oh, yeah, I even forgot. The one that I wanted to mention is I usually give someone some sort of rotational row, or like some people call it a gorilla row, where you're literally just reaching with one arm and rowing with the other to facilitate that rotation. You can do it with a band, you can do it with dumbbells, anything like that. I think that's a really, really good exercise just to get more mobility going while you're simultaneously getting periscapular muscular activation. All right. So, Mark, moving on, we finally get to the topic.
Hmm.
Something that
Yeah,
we
yeah.
disagree on. Ribs. Okay. Okay. So, I think that Mark and I probably agree on there being some upper rib dysfunctions. I think that's fairly common to kind of run
Like first and
into.
second.
Yes, yes.
Sure.
And then we may run into some disagreements in regards to lower ribs, like mid, anywhere from like 3 to 6, 8, somewhere around there. These are some places that I've noticed that some patients will say that they have pain there, pain with rotation. Same thing that we talked about for thoracic, right? What are you typically seeing for these types of presentations, the upper ribs especially, because I think that that's the one that we both agree that we're going to see issues on.
I don't know what. I don't even know if I believe in this upper rib uh mumbo
Ah,
jumbo either. Man.
okay.
This is the thing. Like I may, if you're thinking like rib 1, 2, something like that, like I just see like with the training experience I have, to me I'm probably just addressing it more so as a if it responds to movement, it responds probably positively to me. It's a derangement, right? So and how I get to that conclusion is probably different than someone who's maybe more manually trained or more biomechanically trained, that they're looking at restoring mobility in a certain area, right? Where I'm just looking to restore mobility and reduce symptoms with, having the person move. And that's not to say people trained other way aren't doing movement or exercise, or that people with MDT training aren't doing manuals. I think we just view it differently, right? So maybe, like, let's just say it's a upper rib dysfunction, right? And I view it as a derangement, right? We might see, pain in that CTJ or that like upper scapular type area. It may just be like asymmetrical type symptoms, maybe pain with like a deep breath, things like that. Maybe a little bit of difficulty with like overhead type activity that requires that extension, or that maybe rib elevation, things like that. But I think the way we address it is probably different, right?
Okay. So if you're addressing it differently, how exactly do you do that? Like, what's your approach?
Well, it would be similar to like any other kind of presentation with pain, where I'm just assessing their movements, see what helps, see what doesn't help or makes it worse, and then just prescribing based on that. So maybe, right. So it's just different. I mean, I think just generally speaking, the regardless. I mean, yeah, generally speaking, regardless of the presentation, the mechanical assessment's gonna stay the same, right? So if it's an upper rib, or let's just say like we're talking upper rib type area, to me, I'm thinking cervical right away. So I'm gonna address it that way, and I can say that like I can't really think of any. Not that I haven't had patients that. Not that all my patients get better, but I can't really think of a presentation for that area where I've been like, okay, it hasn't responded to cervical, right? You know what I mean? Or that
Okay.
I've been like, oh, I need to, it could have been a rib. And just my main
Hmm.
issue with the rib type thing is there's not really like data to suggest that like this is the standard treatment for it and this is what's suggested, and that it's even like an identifiable or reliably identifiable, measurable like type of issue that needs to be addressed. But yeah, I mean, when I was in school, I learned, right, the first, well, here, like first rib mobilization. I mean, if we're looking at just like targeting that area, it's from like an MDT point of view, it's essentially just a lateral flexion mobilization.
Yeah, I would
So
definitely agree
I
with
mean,
that.
that's what I like. We see so like I think regardless of how it's approached, we end up in we get to the same
The same
conclusion, which is
spot.
like, which is like having the patient be asymptomatic, right? So there's a lot of overlap in these techniques. I think the assessment's different, but the end goal is similar.
Okay, okay. I'm picking up what you're putting down so far. So I definitely think like rib one, I don't want to say it's a myth. I just don't see a whole lot going on with rib one. I mostly find issues like if I'm going a little bit lower, right? But before we even jump into this, I want to preface this is before I even check rib, I am exhausting the spine first. I'm exhausting, like Mark said, cervical and thoracic to make sure that it is truly coming from what I believe to be the rib. Okay. So if I am getting them to move and we're getting some sort of symptom response, it's not changing, right? Or if they're like if they're pretty hypomobile and I think that they are going to need a manip to help clear out their symptoms. We do that and their symptoms still persist. So they haven't responded to repeateds. We mob or manip and then we return back to repeateds and still get nothing, or their pain is just like it's still lateral to their spine. That's usually where I will go, and I'll usually assess it. Like I am not the biggest believer of like being able to palpate different things. I think I have good enough of hands to be able to detect these things, but I don't put in a whole lot of reliability behind it. So it's not like I utilize this all the time. But if I do decide to use it, I'm usually going to rib 2 and 3 first before first rib. I just don't see that being a huge issue. And the other thing is, my biggest gripe with this is if you mobilize rib 1 and rib 2 and 3 are deemed to be also problematic, but undetected, you're essentially just mobilizing the rib onto something else that is potentially not moving super well. So you're kind of running into a wall. You're just not going anywhere. So that's one of my bigger issues with that. And to me, I'm usually going to ribs 2 and 3 and just going from bottom up in that case, where I'm usually mobilizing them. From what I've noticed, they're usually going to be more elevated. And so at least that's the terminology that is used to describe rib dysfunctions for the most part. But that's usually where I'm at when it comes to addressing upper ribs. I do think that for the mid-range ribs, those I do think can be more problematic, right? Like you've addressed T-spine, you've cleared that out. They're still having symptoms. Like when you poke that rib and compare bilaterally, that's where I'm like, oh, like that thing is actually sticking. Like you can usually feel it. You can't depress it as much. It may be guarded. I don't know necessarily if it's quote unquote like rotated or slipped or any of those things, right? I think it's described as that in the literature. But from my understanding is if I'm manipulating something, I'm giving you like some sort of input, and then that alone could be enough to reduce the muscle guarding that they're having. That could be enough to give them that analgesic effect and get them to feel better. Do I know that it was necessarily the rib that needed to be mobilized? I mean, I mobed and manipulated the T-spine and that didn't make a change. If I do that to the rib and it creates that change, I would be more likely to say yes, but I can't confidently say it. I mean, I kind of did just body slam the patient. So maybe that is what caused the change, right? So
Yeah,
I think that
your approach is is quite measured, right? In that you're saying like, it seems pretty consistent where you go spine. Okay. You did your full force progression with spine. It's like, okay, why not? I know that there is another joint in this area, right? Being the cosmovertebral joint. Let's go from, the intervertebral and I'll move over. This is where this is more so the location of their symptoms. And I'm going to give it some kind of input. to see if it has any effect on their symptoms, which is, when one of our very first episodes podcast was about, and then you're retesting afterwards, right? So you applied your intervention, test, retest. I'm sure you have self-management strategy for this too. So it's checking all the boxes, right? And it's right. The explanation is not like, you were a bit cautious with your explanation. Okay, is it a little bit rotated, or it's kind of sticking out? Maybe it's just the thoracic segment. Maybe that's rotated relatively, and that's causing the rib to stick out. I mean, it doesn't really matter as long as you're getting some kind of symptomatic response. And you also described to us your thought process and how the order in which you apply these interventions, being spine, and then you're moving over if you're not getting a response, which I think to me makes a lot more sense than my initial impression with clinicians who talk about like rib and stuff like that. It's like, oh, this is rotated and twisted, and it's very biomechanical. I've had someone tell me that the like inferior medial portion of their diaphragm was tight and it was pulling this and twisting that. I'm like, you've completely lost me right at that point. But the way you described in your approach to me, it's like completely makes sense, right? You've done a certain amount of movement, manuals, whatever kind of interventions for what you would see typically resolve these symptoms, and for whatever reason it hasn't resolved, this is the next step, right?
Yeah, and I that is literally my decision-making tree when it comes to thoracic/rib, right? Is repeated motions. Okay, not seeing anything. Are they suitable for a mobilization or a manip? Can they tolerate it? Yes or no? If yes, I perform it. And I literally go down that route where it's like, okay, I've mowed them. I've done I've assessed it. Like, I've done a grade 3. Awesome. Now I'm going to do an MDT style mob. And then if that's not changing, I may even do a grade 4, which is not what I typically like, from what I've said previously. That doesn't work. I'm a nip. I recheck repeated motions. Any response, right? Like all these things, I'm constantly checking, rechecking, making sure that my applied interventions are creating some sort of change. And then if I don't get that, that is where I go to rib. And the thing is, if I am going to rib for a mob or a manip, it should have responded to the repeated motions exam. I am not moving their T-spine alone. Their rib is moving too, right? So that's why I'm not doing some special rib repeated motions.
Yeah, right. So like you're saying,
that would be crazy.
Yeah, exactly. And I'd say the same thing. Like if you're moving your thoracic spine, I mean, your ribs are moving too, as long as you're breathing, right? And I think, I don't know if you do this. I guess the most amount of rib I would do is that if someone's having more of that, especially if someone tells you like, oh, I have pain when I take a deep breath. And to me, I'm thinking thoracic, right? Is there rib involvement? I mean, maybe they're moving, but I'm addressing it from the spine first. But like, I think a simple way for self-management to continue to encourage, let's just say, the rib mobility. I don't know if you do this, but I'll have them do their thoracic mobility exercise. And when they extend and expand, I'll have them inhale and try and, almost breathe up into their chest to get those like mid upper ribs, little hold, and then come back down, right? So, I mean, how do you talked about a lot of manuals for the ribs. Like, are there anything, like, what does the exercise look like? Is it your regular thoracic things? Are there specific rib exercises, or do you tweak certain movements in order to get a little bit more rib movement, if you will?
Yeah, so I definitely agree with the inhalation, because when you do that, you are getting chest expansion, right? Like that's like one of the things that if they are having issues with that, if they were having pain with deep breathing, this is a way for us to facilitate that. What I'll say is that for most patients, when they have a true rib dysfunction, from what I've seen, you manip them once and they're done. You do not have to manip it again. It is not a common presentation that I see where I need to go back and redo that. These people are usually acute, and when it happens, they're just like, oh my God, I can't breathe, I can't turn, I can't do anything. And then you hit it and they're just like, oh, it's gone. it's the people who are chronic who have this where I'm like, okay, I am a little bit more cautious of this. I am not fully sold on having to manip this and then doing it again and again and again, and I'm getting nowhere. These are the people that I think are going to benefit more from generalized mobility and then learning how to control that, right? And I to answer your question, I don't change a whole lot. It is mostly thoracic mobility or like thoracic musculature that I'm looking to address. Your ribs are going to move. Just let them move. You're not doing anything special per se to it. The only thing that I would say is maybe I look to open or close that segment a little bit more depending on their symptom response. Like, do I add a little bit of rotation? Do I add a little bit of side bend? Sure, maybe. But that's about it. I'm really not doing anything. I'm just fine tuning the movement to best suit my patient and their symptom presentation. Like, Mark and I probably talk about this where like we're not trying to overcomplicate stuff. We really do just stick to the basics. The only thing that we probably do is we just tailor it to our patients to make sure that we're getting the movement that we want, that we're the quality that we want as well too.
Mm-hmm. Yeah, and if you haven't picked up on
we're
it
checking
yet,
in.
yeah, exactly. If you haven't figured this out yet, like we follow a certain pattern, right? It's like, okay, what is the most likely, not movement, but what, like let's just take this thoracic rib, for example. Kane's talking about that rib lateral type pain. Well, in that presentation, what's most likely to resolve their symptoms? Probably thoracic based movement. If that's not working, okay, what else is that area? Rib type area. Okay, I know some manual techniques, interventions for the rib. Let's do that out. Okay. Maybe that resolves their symptoms. We can apply that to any kind of body part. And as long as you have that kind of foundation, those foundational assessment skills, you can really begin to, like I was saying earlier, like we kind of use MDT based as an assessment, but the movements aren't, owned by, McKenzie Institute or anything like that. They're just movements, and they use those movements to standardize them. But you can apply this kind of assessment, not just MDT, but your own kind of interventional assessment, and then use whatever movements you feel like would benefit the patient.
Yeah, I think like the really good thing about this discussion was like going into this, I thought Mark and I were finally gonna have our first like big disagreement, big discussion point. But
listen, dude, I'm not treating a rib. You can't make me, okay?
But okay, the main thing that I want to get across here is, lo and behold, when we have this conversation, when you have a solid thought process and justification for what you're doing, why you're systematic about it, it makes it so much easier for people to actually be like, no, I get why you're saying this. Like, I understand why you're doing it. I may not do it, but I understand why you're implementing this, right? Like, that is something that I think that so many PTs could really, really benefit from, because that's just going to help you better understand why certain people practice the way that they do, what they're seeing, how you can implement it in more seamlessly into your own practice. And I think that, to me, it's just how you should be. Like, you really should just be justifying what you're doing, because if you can't do that, there's probably going to be an issue running on down the road where you don't have that justification and you're just doing things just to do them. Exactly. Yeah. And not all presentations are the same either. You need to make sure that you're going through and investigating and assessing them in a standardized way. And we say that, or at least I say that, it sounds counterintuitive. You're doing things the same for everyone for the sake of finding differences within each of your patients, so you can then fine tune your intervention to best fit or match what that patient needs, right? Mark, anything you want to add to that?
No, I mean, like you were just saying, maybe thought this point we would disagree on, and I think there may be small aspects that we still do, but listen, like you talk about justification and then going through the standardized process, we both use this process. All you had to tell me was, hey, I completely exhausted thoracic, I completely exhausted cervical and thoracic, and now I think they could have pain coming from the ribs. So I tried that and it got better. Okay, cool. Like, and I know what process and system you went through. So I trust that you did everything I would have done. And now you're just moving on to what's next in your algorithm, right? What's next in mine may be different, but I think we both have sound justification as long as we're applying that standardized process. We're checking the patient and making sure they're getting symptomatic benefit.
Absolutely. Absolutely. All right. Now, there's one last segment here that I just want to touch on briefly, and that is similar to thoracic, where we talk about MOBs and manips, different tips for it. I know Mark doesn't do it a whole lot, so I'll probably be commandeering the section for a little bit, but I'll be brief here. So the biggest thing that I would say for when you're doing a rib manip is you gotta get lower than what you may expect. Have your patient up nice and close to the edge of the table. Get low in a squat stance so that way you can roll your patient far enough so that your pressure and your force is going to be directly over your hand. Your patient is going to be at an oblique angle. The biggest thing that I can say is getting that down, being confident with it, because when you have an acute rib issue, they're going to be in a lot of pain. That you are not going to get a whole lot of chances to hit this. You get one chance, and if you don't nail it, they're probably not going to trust you. Right. So this is one of those things where it's like, you gotta commit. If you sense that they're guarding, back off, because you're not going to get it. If you are able to get them to relax, they're able to tolerate MOBs, and then you're going for that manip, you need to make sure your setup is crisp and clean, and that you hit that manip hard, and that you're ready to actually commit to it. You got to have confidence when it comes to this. The second thing is for MOBs. One of my favorite MOBs is second and third rib. They're in sitting. You're putting your hand, like your hypothenar eminence or your pisiform, right on top of the second and third rib, and you're inferiorly gliding on it. I think that this is best with skin contact so you don't slip. Doing it over a shirt is impossible, but obviously ask for permission. But this is probably one of the best symptom. Like, I usually notice a significant reduction in symptoms if this is what I am seeing as the deficit. And you can get a good amount of force here. It is fairly well tolerated. It's uncomfortable, but it usually does a better job of addressing this compared to trying to mobilize rib one. The next tips, which are two more, and then we'll finish up and conclude this episode. But the next tip is to be cautious if someone has floating rib pain. These ribs don't attach to anything. There's nothing stopping it. God forbid something goes wrong. If you try to manip it, I would be very, very cautious, because if something happens and then you fracture that rib and something could puncture a lung, I do not want
it. Shouldn't. Does that happen?
It definitely can. I've that is one of the things that I've been told multiple times, which is like lower rib pain. Like, even if it's not a floating rib, if it is just a lower rib, I'm not manipulating it. I can't get access to it. It's very difficult to get to. I've tried it and I'm like, nah, I can't confidently do it. And I've practiced it, and it's one of those things that happens so rarely. I'm like, I'm okay if I don't know this skill, or if I don't have the technique or the technical prowess for it. I'm just gonna mob it. I'm just gonna keep them moving, and then usually I get a symptom response out of it, right? I don't notice that this is something that needs to be manipped. Last one. Do not manip a costochondritis or anterior dysfunction. These are the patients where you palpate their sternum. You can literally feel a rib poking up compared to the other side. And this is one of those ones where it's very uncomfortable. You can try different stretches similar to the thoracic one that Mark mentioned, the modified butterfly. These are the ones where if you continue to expand on their chest, I've had a lot of patients, I've had it myself, where I do something like that and you just hear a pop, that thing goes right back into where it should be. Their pain's gone. right? So focusing on that chest expansion is going to be super, super helpful. You can mobilize it. I found that to be helpful as well. You literally just have them lay supine. You put your piezoform right on top of the rib, and you're looking to glide that inferiorly as well as laterally too. And sometimes that helps. I usually notice that it does, and it gives it enough movement to be able to get it to reduce with other mobility exercises. But these are all the tips that I would recommend for most people when it comes to handling ribs and their manual skills. All right, Mark, is there anything else that you want to add to this episode? I feel like we hammered, absolutely hammered T-spine and ribs tonight. I am very, very happy with getting out all this information. I think that it was a really, really good conversation for us to have, to see like things that we agree on, things that we disagree on, and then just obviously showing people like, we can have disparities in our practice, but still understand where the other person's coming from. And this is where I hope that this podcast is able to inspire and influence other people to have the same type of mentality, the same type of discussions to facilitate that growth.
100% agree, man. I think maybe the most important part of this episode is what we talked about in the beginning, where you can use the thoracic spine to influence cervical and cervical and lumbar, right? I mean, it just has a good amount of interplay, especially when it matches the patient presentation. On the other hand, we talked about the more specific thoracic spine presentations, pain with deep breathing, wrapping around pain towards the chest. That is much less likely to be something that's cervical related. We talked about different kind of treatments, right? We pretty much default to our MDT type repeated movement assessments. Kane talked about his mobilization, manipulations, things like that. Kane talked about when you're not getting the desired response from just spinal movements from thoracic, maybe you're looking at rib, right? He has a little bit of insight onto what he goes to, different manuals, and different treatments that he uses when you're having that kind of stubborn, laterally located thoracic spine pain. All right. Well, that concludes today's episode of the PT Good Podcast. Subscribe to us on whatever platform you listen to us on. Follow us on Twitter at PT Good Podcast. We thank you for listening. Hope you enjoyed. We'll see you on the next episode.
Miss you, love you. Bye.